Hey there, everyone. Thanks so much for being here for episode number 295. I can't believe we're closing in on 300 episodes already. I'm so grateful for your listenership and support, as well as your feedback and positive ratings and reviews of the show. Speaking of which, if you feel called to leave one, by all means, head on over to Apple Podcasts or Spotify and leave a rating or review. It would be so appreciated. As a reminder, you can also check out the podcast over on my YouTube channel in case you want to see this on video instead. So today, I'm excited to introduce my guests, wellness professionals Sara Russell and MaryAnn Marks. Sara owns Build, Nurture, Restore, where she mentors clinicians and nutritionally supports clients with complex reproductive issues. MaryAnn is the founder and CEO of LabSmarts, a bio-individual blood work analysis software. They teamed up for their current project, What You Never Learned About Blood Work in Preconception, Pregnancy, and Postpartum, after discovering major gaps in the now widely used functional blood chemistry ranges that so many naturopathic and functional medicine doctors and practitioners use in their practices. They shed light on the concept of blood test reference ranges, explaining the differences between conventional or standard ranges and optimal or functional ranges. They introduced the concept of bio-individual blood work analysis, highlighting the need to customize reference ranges based on individual needs. One of the key points discussed is why functional ranges do not work in pregnancy, postpartum, and lactation, and what should be done instead. They emphasize the importance of adjusting reference ranges by trimester and reevaluating the interpretation of blood tests during these critical stages of reproductive health. We explore the specific blood tests that are typically run during preconception, pregnancy, and postpartum, including commonly overlooked markers such as B6, vitamin A, and zinc. MaryAnn and Sara provide valuable insights into the top 5 tests with different ranges during pregnancy, as well as the need for pregnancy-specific ranges for thyroid hormones. Their groundbreaking research has uncovered the discrepancies in pregnancy and postpartum ranges that other clinicians may overlook, and they discuss how this new information will impact the work of fertility and reproduction-focused clinicians. I hope you love this episode as much as I did. Hi, Sara. Hi, MaryAnn. Thank you so much for being on the podcast with me today. I'm so thrilled to have you all here.
Thanks for
Thank
having
you
us.
so much, Nicole.
This is so great. I feel like this conversation is going to be so good. And as I was saying to you both, I'm going to learn so much, and everyone who's listening, you will too. So I really wanted to start off with both of you just sharing a bit about your background and how you teamed up to do this work and, what the nature of this work is.
Yeah. Do you want to go, Sara?
Sure. So my background is, I'll start with the beginning of my nutritional therapy training, which I began as a result of the experience that I had postpartum with my son, who is now almost 12. I realized how important nutrition is for health at that point, much more than I had realized before. And I was inspired at that moment in life to just to end my career as an Italian language literature and culture instructor at UC Berkeley, and to pursue nutritional therapy, because that felt so much more meaningful. And I at that point, my idea was to work with people during preconception, pregnancy, and postpartum, and really help reverse the paradigm by bringing in real food and epigenetic awareness and all the good stuff into my work. So I've had an active clinical practice for over a decade now. And during that time, I've worked with a lot of people in this realm, both clients and colleagues. And I've just really tried to keep up with the learning and what the needs are along the way. And one of the big needs was having a consolidated place where functional ranges existed for pregnancy and postpartum and lactation. And they just weren't consolidated. So I ended up doing a lot of dispersive research to help my clients understand what was going on in their labs during pregnancy. And a mutual colleague and friend of ours introduced us about, I think it was over a year ago now, and we started talking about this project, which is really all about bringing awareness to how ranges change during each trimester of pregnancy and during lactation and the early postpartum period.
That is amazing. And I was thinking, as I was reading through everything that you both shared with me prior to this episode, that um this is just not at all known. And the fact that you have taken it upon yourself to just do all of this research and consolidate this information, I feel like you're doing a massive service for all of us who are involved in women's health in some way or another. So thank you for the work that you're doing. And so MaryAnn, can you tell us a little bit about
Yeah.
your background and how you guys, came together? I can't believe it's only been a year,
Yeah,
by the way.
yeah, it's been a while since we've been working together. It's been fun. But so I'm a techie person. I came from the tech field, and I was in a corporate job. And one of my last jobs was I would travel around to police departments all over the country, showing them how to implement video in their cars and in towns and everything. But traveling around, I was eating bad, gaining, I was 50 pounds overweight and just felt terrible, always in pain. And I don't know, somebody gave me a book on what they never teach you, the natural cures or something. And I just started reading that and started getting healthy on my own just by changing what I was eating. And I'm like, oh my gosh, like it's all about food. And I'm like, I have to leave my corporate job and go get an education in this and teach everybody this. And so I just left, like in 2014, I left my job and went to Bowman College to get a nutrition consultant certification. But being a techie person, the part in there when they started talking about blood work, I just was like, oh, this is so fascinating. Why doesn't everybody know this stuff? Why don't I know about it? And so I started creating my own spreadsheet, and then I started working with clients. And, I realized that, that is not my thing. Like, I really love this blood work stuff and looking at patterns. And I started automating my spreadsheet, and I'm like, I think I should turn this into software. And I know that I can help a lot of practitioners, look at blood work more effectively if they had some software instead of, because there's so many people that have their own spreadsheet. Then I started realizing that even in this, you can't do it all in the spreadsheet because ranges change based on different individual traits of a person. And so in the software, and which is why I call it bio-individual blood work analysis. That's what I call, like, the tagline of my software, Lab Smarts, is that I adjust reference ranges for different, male and female. I mean, no matter what, that male and female have different, their blood looks different, different age groups. I have ranges for different for the sex hormone markers I have in the software. There are different reference ranges for different phases of the menstrual cycle. And so you can select the menstrual cycle and use that appropriate range. And then I initially had some pregnancy trimester specific reference ranges around pregnancy for around red blood cells and just hemodilution in general. And then Sara became one of my users, and we started talking, and she's like, well, there's a lot more adjustments to all these different markers during pregnancy. And so, just recently in the last few months, I released trimester specific reference ranges for over 100 different markers that I have in the software. And Sara and I have been researching together, and we're like, well, there's so much here. We should educate people and maybe turn this into a class. And so that's what we started doing about a year ago.
That is so cool. And it actually makes me think so much about the fact that I get women coming to me all the time, and they'll say things along the lines of, my doctor didn't want to test me because they tell me that hormones fluctuate from the menstrual cycle. I'm like, yes, they do. But there are norms within the phases of the menstrual cycle that you can be looking at. So are you guys as frustrated about that as I am? Because it's so annoying to get that when they're clear changes based on the phase of the cycle.
Right. And nobody really, just yesterday I was working with somebody. I still work with people on the side just because they want me to look at their blood work. And I'm like, well, go back and ask your doctor for these. And they're like, oh, no, they said I don't need them. And I'm like, well, it's just because they don't know how to interpret them. So yeah, there's frustration around all of it. Getting the test ordered, having the doctors interpret them properly. Yeah, there's that's saying, everything looks normal when you don't feel normal. That's what people hear all the time. And that's what we're here to help educate practitioners so they can educate their clients to know that, normal is not healthy, not optimal.
Right. Absolutely. Sara, I didn't know if you wanted to chime in on that too, express your mutual frustration.
Sure. It's really interesting. I mean, before pregnancy, it sounds in the, like in the allopathic world, like everything is normal and everything goes. And then in the pregnancy realm, when ranges aren't properly applied, that are specific to what happens in the trimesters of pregnancy, what happens is a lot of the time a patient will get back their comprehensive metabolic panel and complete blood count, and many things will be flagged as abnormal, when in fact, when you adjust those numbers to reflect the actual trimesters of pregnancy, they're completely normal, or there will only be one or two things out of line. So, I mean, I also want to give a little grace to allopathic health practitioners who are incredibly overworked, and they aren't interested in functional health. It probably is seen in the allopathic, in the standard allopathic world of primary care as a luxury and a privilege to be able to access, something like, a full thyroid panel. Oh yeah, I roll those people who want to feel okay on a daily basis. I mean, what is wrong with them? Allopathic primary care is interested in helping people who have disease states, and they're really good at diagnosing and, to some extent treating some of those diseases. So I just want to be a little bit gracious to the hardworking people in allopathic medicine out there, because sometimes we are really hard on them, and I get as frustrated as everybody else here with them, but I also try to see that side as well.
Absolutely. You're so right. And I agree. I tend to be hard on the system too. And I think it's just because of what I see on a daily basis. And I bet you both can relate to that too. But at the same time, the whole system is a mess, and it needs a revamp in a major way. So yes, I think we can totally acknowledge that. I was thinking that maybe we could sort of start with the basics on all of this and actually just talk about what a blood test reference range actually is. And then also the differences between the conventional or the standard test ranges versus these optimal or functional ranges that we've been talking about. So can we just break that down for everyone who's listening? Because I think there's definitely a misunderstanding around what that even means.
Yeah, I'll take that one. So on the lab report, that you get from LabCorp Quest or wherever, there are those reference ranges, and they mainly represent 95% of the population tested at that lab, tested across the country, wherever. And so they're just using the population data to get that range. And they use a normal distribution curve, like a statistical Gaussian normal distribution. And that's why sometimes they call it, oh, that's the normal range. Well, this doesn't mean that's normal, that's healthy. It's just a normal distribution curve, a statistical term. So you really don't. So who goes and gets their blood work done? Mostly people who have issues. So that pool of reference range is made up of people that have symptoms and aren't all totally healthy. So the upper and lower ends of those lab range really don't represent an optimal health. And so we in our world, in functional medicine world, we have these things called functional or optimal ranges, which are a tighter set of reference ranges. And I made this chart in presentations that I give, where I start with that it goes high, it starts high and then goes low in accuracy. So we have the reference ranges on the lab report, and then we have optimal ranges where we can do just one standard deviation from the mean, because the reference ranges are 2 standard deviations from the mean. 95%. One standard deviation from the mean makes it a little tighter, gets it around 65%. But then you get it even a little more accurate, where you use evidence-based reference ranges. So I use studies, like a lot of insurance-based studies, where the life insurance, where if your GGT is over this number, you're not going to get life insurance. Or so there's good studies out there, mortality studies that I use, where your marker's over this number, you're likely to have cancer or die early. Or so there's a lot of, so that makes it even more accurate in terms of how we want to look at it. And then the values that fall outside of those optimal ranges identify some imbalances in different body systems that we as proactive practitioners can help our clients address before those numbers fall outside of the lab range. And then that justifies the doctor to prescribe a drug. But one more accurate, and where I take it a step further, is I call them bio-individual optimal reference ranges, where then I adjust all those ranges based on the bio-individual traits of that user that you're defining in the software. Age, like I mentioned, ethnicity, there's some markers that change with different ethnicities. pregnancy trimester, menstrual phases. Elevation is a cool one that I have, where if you have a client living in a higher elevation city like Denver, well, they're making more red blood cells because the barometric pressure up high is less, so they're breathing in less oxygen every time they breathe, so the body overcompensates by creating more red blood cells. So you can't compare reference ranges for somebody living at a high elevation to somebody living at sea level. So we adjust for those kind of things. So that's what kind of bio-individual blood work analysis or interpretation means.
Oh, cool. It's so cool. I did not know that about the higher elevation, about that changing your blood work.
Right.
And I bet lots of people don't know either. So it's really good to hear that. And so now I'm thinking about people who live in Florida versus Denver, and if their blood work comes back, or when their blood work comes back different, and no one even flags that.
Right. And a lot of times those people living at higher elevations. So if you're just looking at them compared to the sea level reference ranges, their numbers are always going to look higher. And so you're just going to say, oh, you're probably dehydrated. Go drink some more water. What meanwhile that, if you adjust those ranges upward, like we do based on the different increment, things will look normal. Or let's say they're normal, and then you adjust them upward, then it shows they have anemia. So if you're not adjusting those ranges appropriately, you're not really identifying, possible conditions.
Right. Okay. So can we talk a little bit about the menstrual cycle, and then pregnancy, postpartum, and lactation time? So your whole premise is that functional ranges as they stand right now don't really work in these three phases, the pregnancy, postpartum, and lactation time. So how have you adjusted for this? Like, what have you done to get to the point where you have clear numbers that are considered normal for these three times in a woman's life?
Sure. Essentially, we did a lot of research. So, for example, the research that I've done over the years has been basically informed by a client sending me their lab test results, and me trying to understand why something was off.
Right.
So I would just research markers that were off on somebody's report. I would just do a search on PubMed for, say, white blood cells, pregnancy, third trimester. And then I would look at the research literature that would come out of that, and I would actually learn, oh gosh, there are different reference ranges for pregnancy, and the farther it advances, the higher the white blood cells get, and the higher, more specifically, the neutrophils especially get. So what might look like an infection in late pregnancy is actually just normal physiology and normal immune system changes. So that's just an example of the approach that I've taken over the years. And when MaryAnn and I started collaborating, we got a lot more systematic. So I basically learned things, piecemeal along the way. Like, for example, alkaline phosphatase. I learned from working with breastfeeding clients that that alkaline phosphatase can stay elevated for up to 18 months during breastfeeding. There was a really interesting study that was done on Ghanaian women that ascertained that, and there are a lot of research papers on that show how alkaline phosphatase elevates in pregnancy and in the early postpartum period, and a lot of that has to do with the in pregnancy, it has to do with the placental activity, and in both pregnancy and postpartum, there is a bone fraction isomer of alkaline phosphatase that is active, that would not be as active in a non-pregnant, non-lactating state. So learning all these things has been really useful. And then in our project, systematically looking at range by range, by area. So, for example, we looked at the complete blood count, at the comprehensive metabolic panel, at the thyroid panel, and I had already, used, for example, the Teats book of clinical chemistry as a reference when working with clients during pregnancy on thyroid ranges. So I was aware that many of them changed during pregnancy by trimester. So I was just doing a lot of work of painstakingly every time looking in the book, or looking through my notes, marker by marker. So for me, just even seeing that in Lab Smarts, we can just put in the the patient's values and have that adjusted on the basis of our having told the software whether the client is pregnant, what trimester of pregnancy they're in, or, you know, if they're lactating or whatnot. It just adjusts things, and that's just, it's amazing.
Makes your life easier.
Yeah, for sure.
It
Yeah,
does.
it helps it free up my time to do, you know, just to do a better work in clinical practice versus just spending a lot of time, you know, cross-checking markers.
I feel like this is the definition of working smarter, not harder, ladies.
Sure.
This is it.
Yeah.
Can we go back to alkaline phosphatase? What is that? Because I don't know what that is, and I'm sure that
Yeah.
everyone who's listening might want to know too.
Sure. It's a liver marker. So, you know, for example, I have worked with clients during pregnancy and postpartum who have autoimmune hepatitis. So it's really important, you know, like whether you're working with somebody with pathology or without pathology, to keep an eye on people's, you know, routine blood work. So during pregnancy, your patient is going to get the comprehensive metabolic panel run at least a couple times.
Yeah.
And if results get flagged as being out of range, you know, like whether or not they have a pathology, you need to understand like what's going on. So alkaline phosphatase, because it is the number can be dependent on the liver fraction or the bone fraction, or, you know, placental activity during pregnancy, and also zinc status. It can mean different things. So, you know, we can sometimes it's assumed correctly, and sometimes it's just assumed that low alkaline phosphatase is zinc deficiency, and not necessarily along the same lines. You know, somebody could have zinc deficiency and be above the range, above the, you know, normal non-pregnant range of alkaline phosphatase just because they're pregnant. And that doesn't mean that they are zinc sufficient. So
Right.
it's important to be savvy to those nuances, because otherwise we can make incorrect assumptions both ways, both assuming that things are fine when they're not, or assuming that things are not fine when they are.
Totally. And that's what's the acronym for that on the blood work? Because I feel like I know the acronym, I just didn't know the name.
Oh yeah.
It's
Yeah.
like
ALP or
ALT, right?
Phos,
Yeah,
usually.
ALT.
No, ALP.
Yeah.
Or LP?
ALP, yeah.
ALP.
Okay.
Or
All
they
right.
usually spell it out though, phos. Like the
Oh,
three
they do?
liver
Okay.
enzymes on the CMP, alkaline phosphatase, ALT, and AST.
Right.
And they're
Okay.
all really not supposed to be in the blood. I mean, their liver enzymes are supposed to be in the liver. So
Yes. Okay. So that's where they're supposed to be. Okay. So then can we talk a little bit about blood tests that should be run? I'm curious if they're normally run, because you mentioned preconception, pregnancy, and then postpartum. And so I'm wondering about whether testing happens across the board during these 3 phases. So I feel like I hear conflicting information from women when they come to me and they're either trying to conceive or they're pregnant, and they don't realize that they need to have certain labs run during these times. So can we talk a little bit about that? Maybe we start with preconception time.
Yeah. Do you want me to answer this, MaryAnn?
yeah, you're good at the preconception.
Okay. So what will get run and what doesn't get run really depends not only on what the patient knows and asks for, but also what the practitioner knows, and not only knows about, but also knows how to interpret. So if somebody comes to me, preconception, I like to see a number of markers that most people are not running. So, you know, a lot of people will run vitamin D, will run a comprehensive metabolic panel, will run a complete blood count. Many people in the functional world will also run a full thyroid panel with antibodies during preconception, especially if the person has had any struggles with infertility and or miscarriage. There are some additional markers I really like to see. I like to see retinol. I like to see vitamin B6. I like to see folate, B12, methylmalonic acid being the preferred marker versus just regular old serum B12, which is a little bit less accurate. I like to see hemoglobin A1C. If I'm working with both members of the couple, which is actually preferred if the couple is trying to conceive, there are some markers in the male that I also like to see. You know, so complete blood count, comprehensive metabolic panel. I didn't say iron panel, but a full iron panel for both male and female individuals. And I also like to see zinc levels on zinc and copper levels on the male side, because those are so important for sperm health and sperm function. Depending on what the female's diet and health history is like, I may also want to see zinc and, you know, sometimes even copper, depending on what the hormonal piece is looking like on a female preconception panel. So there is some individualization that happens. Also, you know, males, I always want to see their vitamin D levels as well. There are some additional things that that I like to see depending on what the individual health picture is like. But, you know, running these markers can help me understand better how to match a person to the best prenatal multivitamin for them. So there are some really good ones on the market, but not, you know, and even some really great companies. Like you know, there are some companies that make multiple high quality prenatals, but if you actually know the person's B6 levels, so this is one that that is really important. So B6 in high quality prenatals can vary between 2 milligrams and 50 milligrams in a daily dose of prenatals, and that's a huge difference. And if I know the person's B6 levels, then I can help match up the person with the prenatal that is appropriate to them without causing any B6 toxicity or putting them at risk of having more severe morning sickness, because low B6 can cause morning sickness, but high B6 can cause toxicity, which can toxicity symptoms of B6. It's the only nutrient whose excess or deficiency can both cause neuropathy. There are many nutrients whose deficiency can cause neuropathy, but only B6 will cause neuropathy in both excess and deficiency. And when you look at that difference, you know, it's a 25-fold difference between the lower end 2 milligrams and the higher end 50 milligrams in the daily dose of a prenatal. It can have huge implications based on whether somebody is at the higher end or lower end of the B6 spectrum, both in positive and in negative. That's just one example. And iron deficiency is something, you know, that some people are more at risk for even before they get pregnant. And you do not want somebody getting pregnant in an iron deficient state, because that can really set them up for poor outcomes during the pregnancy. So I like to see a full iron panel before the person conceives, so that we can correct the iron deficiency before they get pregnant. It's really, really important.
I mean, I feel like just that B6 information alone is so incredibly helpful, because I mean, I hear this all the time. Like this prenatal made me feel sick and I didn't know what to do or which one to try. And I feel like you're taking all of the guesswork out of this.
Yeah.
Right.
Yeah. There can still be factors, you know, like somebody could still have issues with tolerating a prenatal because of reasons that are unrelated to the actual levels that are in there. So, you know, someone with hyperemesis gravidarum could have, could be triggered just by the smell of their prenatal. And that just has nothing to, you know, usually has nothing to do with the levels that are in their daily dose, but it takes almost all of the guesswork and fussing out of choosing a prenatal, for sure.
Right. And then obviously so many other complications that come with pregnancy when you're deficient in certain nutrients too. Was there anything else that you wanted to add about preconception time that someone should be considering?
I mean, it's especially around that thyroid panel. Like, you don't want to go into pregnancy with thyroid antibodies, very high, right?
Yeah. You may not even be able to get pregnant in the first place if you have hypothyroidism or autoimmune thyroid conditions.
That's a great point. And yeah, I'm glad we're going to talk about that a little bit more. I really want to cover that. So in terms of pregnancy time, my understanding is that that numbers change at different trimesters. Can we talk a little bit about what one should be testing and when they should be testing in pregnancy?
MaryAnn, do you want to
when? Well, clinically, you might want to jump in on the clinical when, but I can go through a few different physiologies, of changes throughout pregnancy. Like, I mean, let's say the kidney markers, the kidneys enlarge greatly during pregnancy. And so the EGFR, that's another number, that filtration rate of the kidneys, it's on the CMP. That number, usually like you want it to be 90 or above, but in pregnancy, that number is a lot higher because the kidneys are enlarging to filter out more of the toxins, get them away from the fetus. And so those numbers, kidney numbers like creatinine and BUN, those will decrease because the body's getting rid of more toxins. There's so many different numbers, like just around coagulation, like fibrinogen, a clotting protein. The liver makes a lot more proteins during pregnancy, and one of those is fibrinogen, clotting factor. So it tries to purposely to try to help protect the mother from hemorrhaging during birth. The clotting factors are increased. Like Sara said, neutrophils increase greatly at the end. Neutrophils are needed in our research. They're needed for I forget the name of the veins and the arteries that go from the placenta to the mother that feed the baby, the fetus. You need neutrophils to help create those and model those. So that one of the reasons why neutrophils get so high even up into the third trimester. There's so many, there's, I don't know, hundreds of different changes in physiology. We could talk about thyroid later, but there's so many.
Well, I think that would be, helpful to hear, what testing is typically done during pregnancy that maybe someone who's listening might not know about and would be able to advocate for.
Yeah. So it's really helpful if anybody has any type of history, personal history or family history of thyroid problems, for a thyroid panel to be run every trimester of pregnancy and to be interpreted in accordance with the proper thyroid ranges by trimester. They do change every single trimester. So that's really important. I like to see a full iron panel every trimester of pregnancy, as well as, I mentioned preconception as well. I also like to see a complete blood count and comprehensive metabolic panel every trimester of pregnancy. These are routine lab tests that often, people will already be getting by default. I also like to see, just all kinds of stuff from the comprehensive metabolic panel and the complete blood count that can be helpful in just flagging early signs of, somebody needing a little bit of support with their iron metabolism, or a little bit of, thyroid support. There are some key nutrients. For example, if somebody's thyroid panel comes back just a little bit off, kind of borderline, selenium, iodine, vitamin D, and B12, in addition to optimal iron levels, will all help thyroid function improve. So there are things that can be done both on the functional side and on the medical side. So, if somebody's thyroid panel comes back abnormal for the trimester of pregnancy that they're in, they may be able to get quick and appropriate medication that will prevent congenital hypothyroidism in the baby, which is really important, because that has not only implications for physical growth, but also for cognitive and intellectual ability. So preventing that whenever possible is really important. Thyroid panel abnormalities during pregnancy can help identify people who are at risk of autoimmune issues in the postpartum period, including thyroiditis, which is a very common inflammatory and autoimmune condition in the postpartum period. And to some extent, addressing that risk with nutritional support, lifestyle support, and appropriate medication by the allopathic members of the healthcare team can really help prevent some of these flares from occurring, and also make them less impactful on the person's quality of life when they do occur. autoimmune issues of the thyroid can, including thyroiditis, can impact mood conditions in the postpartum period. So these things are really important. And also, running the appropriate lab tests can help reassure people tremendously during pregnancy, and interpreting them correctly, so that people know, oh yes, your white blood cells may have been flagged as high by the lab, LabCorp, but it doesn't adjust for trimester of pregnancy. Here's the reference range that we actually use. Here's the research bibliography. It's completely normal, and it's completely appropriate that your white blood cells and neutrophils are that high. Congratulations. And people are so much less anxious, which is terrific. Who wants unneeded anxiety during pregnancy? There's already so much to worry about.
Oh, yeah. Oh, yes, I would say so. Okay, this
Yeah.
is so helpful. And then what about blood sugar testing? I know you'd mentioned the A1C at one point, I think,
Yeah.
MaryAnn. So blood sugar testing in pregnancy, do you recommend that as well? Obviously, I know that there's the testing that's done sort of towards the end of pregnancy with regard to gestational diabetes. Maybe that's
Yeah.
done more in the beginning. You tell me.
It's done in the early part of the third trimester, usually
Right.
about week 28. So I like to see A1C before the person gets pregnant. And by the way, every time I keep saying comprehensive metabolic panel, but that includes a fasting blood sugar
Right.
level. So when we're looking at the comprehensive metabolic panel plus A1C at the same time, we are seeing, I also like to see insulin in many cases, but not everybody.
I was going to ask.
Just like, with some clients during preconception, I will recommend a celiac panel that their doctor can run, but that's not going to be everybody. So there are some people where I would want to see, what their insulin looks like. And again, the preferred marker for that isn't insulin per se, it's like B12, where we're not measuring the marker directly, we're looking at a better marker. So C-peptide is the preferred marker for a person's insulin status. So if a person has a history of metabolic issues that are, history of PCOS or PCOS like presentations, like we could call it a PCOS like phenotype. And of course, PCOS, there are so many different subtypes. So there are different phenotypes of PCOS. And there could be we could call it a broader PCOS phenotype where somebody isn't necessarily diagnosed or maybe isn't even diagnosable, but fits into an insulin resistant, infertile kind of thing. And many of the things that we do for people with PCOS could be incredibly helpful in optimizing that person's fertility and decreasing their risk of gestational diabetes. So, just even addressing these things functionally, ideally before the person even conceives, can lower the risk so that when they do the oral glucose tolerance test late in pregnancy, more of these people are going to have optimal results. And I think it's very sad to get to the week 28 of pregnancy and say, oh gosh, you have a blood sugar regulation problem. And that's just a terrible time to address. I mean, it's important to address it if that's the first time that you are noticing it. But if we can notice it upstream, that's so much better, because then we can prevent that from, being off ideally in the third trimester. So it's just a lot of stress, and, a lot of damage could have been done already metabolically to the mom and fetus as a result of having uncontrolled blood sugar all along, perhaps. Yeah, I mean, I like to be as proactive as possible without, going really overboard. So some of the additional markers, like insulin markers, would be, specifically chosen for individual people during pregnancy or preconception versus, everybody.
Right, based on their current health status and their family history, things like that.
Yeah.
Right.
Yeah.
Which makes complete sense. Yeah. And then what happens postpartum? Because oftentimes I hear things like, Well, we went for the 6-week checkup, and my baby's fine, but I don't feel fine. And they didn't
Yeah.
really ask about me. And so I feel like that tends to be the case, right? We just put our focus on the baby. And I think it's definitely getting better. There's more awareness of all of these postpartum related conditions and issues. But I'm curious about testing during postpartum. And then also, I love that you mentioned all of the testing in pregnancy, because obviously I feel like so much of that plays a role in how your postpartum will play out, right?
Yeah. Yeah, definitely. Um, and of course, having an optimal nutrition and lifestyle during pregnancy itself will help make those lab ranges just as optimal as they possibly can be,
Yeah.
and your health. So that's really helpful as well. So yeah, in postpartum, it's really useful to look at, again, comprehensive metabolic panel, thyroid, a full thyroid panel with antibodies. If the person, sometimes we forget about TSI antibodies. We always remember the antiperoxidase antibodies, and often we remember the thyroid globulin binding antibodies, but we often forget the TSI antibodies, which are more associated with Graves' disease. So depending on the clinical presentation, it is really important to keep in mind suggesting that the person add TSI. Usually it's going to be a different panel, or it's going to be an add-on marker for those antibodies, because it's kind of like the forgotten thyroid antibody in many cases. So yeah, I mean, those are really the main ones. Just and really clinically just making sure that people are aware of what the clinical signs and symptoms may be for postpartum depression and anxiety. A lot of people experience subtle symptoms that they don't necessarily recognize immediately. So this isn't a lab test, but it's really useful information for a person to have, so that so that if they experience some of these symptoms, they can be proactive. And also, I like to give people resources that help take like the personal shame and stigma out of it. Postpartum depression and anxiety are incredibly common. And, like 30% of white women, and like 45% of Black and Latino women, and sometimes even more. And the rate of postpartum depression and anxiety in Asian Pacific Islanders is even higher. So it is really important for us to think about, not when we're in clinical practice, not to think about just what's showing up on the lab marker, and also to connect postpartum depression and anxiety to the person's bigger picture. So for example, vitamin D deficiency during pregnancy in the early postpartum period is a risk factor for postpartum depression and anxiety. Thyroid hypofunction is a risk factor, and thyroid autoimmunity. Anemia caused by excessive bleeding during the birth that has not been corrected at discharge can be a huge reason for somebody to develop postpartum depression and anxiety. So that is important information that everybody should have postpartum. And also, I like to empower people with information on pelvic floor health, because a lot of the time their allopathic healthcare team is not going to give them any information on that. It has nothing to do with labs, but it has everything to do with having a good postpartum recovery. So just really, when we're in clinical practice working with this population, we are doing people a disservice if we're not looking at these kind of like bigger picture things that we might not think about being directly our job. But if we are in a position where, for myself being a nutritional therapy practitioner, I am the clinician who spends the most time looking at my clients' records, understanding their history, and talking to them. So if I'm not telling them this stuff and giving them this information, I don't know who is. If they're working
Nobody.
if they're working
is.
with a midwife, yes, a lot of the
Right.
time they are getting this information, and it's incredibly empowering. But if they're just working with an allopathic healthcare team, a lot of the time they just don't see or hear any of this.
Right. Particularly the pelvic floor information.
Yeah.
I think as when you really think about it, the fact that women birth babies vaginally and then they're sent home with a baby and no physical therapy at all is astounding.
It's
Right, we rehab knees and ankles and hips and all kinds of things after surgery, but we don't rehab our pelvic floors.
Yeah.
It's so crazy. And
Even after a C-section. I mean,
right. Major surgery.
Yeah.
yeah. Yeah.
I know. I can't deal. It's really frustrating because I feel like I've had a lot of friends say to me over the years that if I hadn't mentioned this to them, this whole pelvic PT thing, they would never ever have heard about it. And I just know that that just seems to be the case across the board. And you know, I feel like as well too, when you have pain or you haven't properly healed, then that triggers this whole internal stress response, which of course creates a whole cascade of other you know, hormonal responses that then lead to potential problems in postpartum, like more anxiety
Yeah.
or more feelings of stress or not being able to sleep because you have pain or whatever. And
Yeah.
that of course it's just a cascade is what it feels like
Sure.
when you don't address
Yeah.
everything fully.
Yeah. And any kind of inflammation is going to result in increased risk of postpartum depression.
For
So
sure.
that, just even keeping an eye on somebody's CRP can be helpful. It doesn't tell you the whole big picture. There are some other inflammatory markers that are more specific that are not going to be run in standard medical or even functional holistic practice. But
There's a lot of markers that are acute phase reactants, negative or
yeah,
positive. And so
yeah,
in the software, we identify those like ferritin. If ferritin is very high, and that's a positive acute phase reactant, and you know there's
yeah,
some inflammation going on. So that, yeah, there's a lot of other markers that you can use to identify inflammation.
yeah.
Yeah, for sure. Are there a few others that you would want to share about for someone who maybe is in the postpartum time, for instance, and thinking about getting some help?
Yeah, in terms of inflammation, just off the basics, like I would say albumin is that's a protein marker, but that's a negative acute phase reactant. So when it's low, I think it acts as a antioxidant. Also bilirubin, which is on the CMP, that acts as an antioxidant. And when that's low, you can infer that there's some oxidative stress going on. TIBC. Uric acid when that's high, GGT when that's high, TIBC and transferrin when those are negative acute phase reactants, meaning when they're low, there's some inflammation. Yeah, there's ESR, sedimentation rate, homocysteine when that's high. And there's several different markers, yeah, that can identify inflammation and oxidative stress that come with just a basic panel.
So good. So helpful. So before we wrap things up, is there anything that you would like to share about how what you're both doing here, your collaboration and this work, can really affect the work of fertility focused practitioners and doctors in the near future, hopefully in the near future?
Yeah, in terms of, go ahead, in terms of the course.
Just in terms of your work in general and like this understanding, what will it be? What will it mean for people who are focused on reproduction and fertility, those kinds of clinicians?
And I know from Sara being a user of the software and how she just said, where when her pregnant clients come to her with all these values that are outside of high and low flagged on the lab report, and she puts them into Lab Smarts, and everything looks normal because we're using the appropriate reference ranges. Just giving your client, relieving her of that anxiety around blood work is huge. And so being able to understand, like Sara said, neutrophils in the third trimester are supposed to be high. It's okay. Like knowing how these different changes happen in each trimester allows you to be a better practitioner, to help your patient, in the right direction and not start going off on different things that are flagged just based on the lab report that aren't correct. And I don't know, maybe you could give maybe some clinical examples, Sara, of how this is helping other practitioners understand how blood work changes in pregnancy.
Sure. Yeah. I mean, just to address the main question, I think that, our main goal really is to help improve outcomes in this incredibly important population that has not been as well served as it should be. A lot of areas of female healthcare, including maternity and perinatal, postpartum care, just have not been what they should be. We're doing, all of humankind a disservice by not paying more attention to the health of, you know, of couples before conception and of the mother during pregnancy and postpartum and lactation. So, never mind the individual and collective health of women. So this is a huge paradigm shift. And I think that empowering people is in this, through this work, is, the teaching practitioners how to accurately understand and interpret these results and what to run before conception even occurs can help improve things upstream from the epigenetic perspective. Even just thinking about, we were talking about oxidative stress a short while ago. And, when clinically, when working with couples before conception, I pay attention to things like migraine in, say, even both either the male or the female partner. So, for example, if I'm working with a couple and the male partner has a history of migraine, I know that there's a higher chance of him having oxidative stress, and that can affect his sperm health. So everything we do to support his migraine from a functional health perspective is help his sperm, and vice versa. So this is really empowering work that not only benefits the health of the people that we have right in front of us, but also the health of people who haven't even been conceived yet, which is, it's incredibly impactful to work upstream, in this epigenetic way from a multi-generational perspective. And, from the point of view of a clinician who's wanting to build their practice, there's nothing more impactful. Of course, if you are called to and passionate about this area, there's nothing more impactful than the family building realm. So, I went into this realm out of passion. And what I noticed when I was building my practice is that when you are focused on family building, that allowing people to have optimal outcomes during preconception, pregnancy, and postpartum is going to bring you so many referrals that will build your practice. I had, people who had struggled with infertility, who successfully conceived and had a healthy baby, refer me, their sisters and their moms and their best friends for whatever kind of health problem they had. I mean, you gain people's trust in this field through doing this really important work, and doing it well is really important. There's just no point in doing it poorly, in my opinion.
Yes. Well, thank you both so much. This was such a great learning experience, and I really appreciate your knowledge from both sides of the spectrum. And I was wondering if you could both share just where we can find your work, and as well as the course on, really understanding all of this for clinicians and practitioners, if that's something that people are interested in.
Yeah. So for my software, it's LabSmarts, LabSmarts.com. You can go there, try it out for free. You get a couple tests and you can see how it works. And practitioners love to give this report to their clients. The clients love the report where we take their values and plot it on these color-coded bar graphs with optimal reference ranges in green, so they can visually see, where their values fall in, and it helps them, makes them feel better. And also we can track progress over time, or we compare current to previous results and let them know if they're trending in the right direction. And practitioners use that before, look at the blood before, do another test 3-4 months later, give the comparison, and can show that client how their recommendations are improving their markers, which is pretty awesome. So that's LabSmarts. And then in Sara, you can mention your site in the course there.
Yeah. So my site is buildnurturerestore.com. And the easiest way to find our course is to follow us on social media. I'm Sara Russell, NTP, Sara with no H, Russell with 2 S's and 2 L's. NTP, I'm at on Instagram and Facebook, and on my Instagram bio, you can just click the link and it will bring you right to the Lab Smarts. I'm sorry, right to the lab masterclass for pregnancy and postpartum.
So we're doing a 6-week masterclass. We have to compile this information and share it, and we're doing 2 hours every Thursday starting in the summer, and we're going to just go through the preconception and the markers and like we mentioned, the important markers, and then we'll break it down into CMP, CBC, and go through the physiology of it in each trimester of why these things change. And then we'll show you, how they change, show you all the different reference ranges and how they change in each trimester. And then talk again about postpartum and then markers and physiology and the changes there.
Excellent. That's incredible. Great. Well, this is such good information. Thank you both so much for all the work that you do and for sharing all of this with myself and my audience today. I really am so grateful.
Thank you, Nicole. Yeah.
Thank you so much for having us. It's been such an honor, and we really love and appreciate your podcast and everything that you do for people in this realm. I mean, you have so much great information in your podcasts that reach so many people and help improve lives. So we really feel like we are aligned with the paradigm that you are a part of and helping spread. So very appreciative.
We're appreciative.
Thank you.
Yeah.
Thank you for saying that. I feel the same way. I feel like there's just so much good information here that you've both shared that has such a tremendous ripple effect. It's exactly what you were saying, Sara, about helping those who haven't even been conceived yet. That's really profound. And I'm just so grateful for this work and this new knowledge that is going to be out there, because truly, I don't know anybody doing this. So it's just really so exciting to see this work out in the world. So thank you both so much.
All right.
Yeah, thank you.
Thanks, Nicole. We appreciate it.
That's a wrap. Be sure to click that subscribe button to join me for more Girl Talk Gone Menstrual in upcoming episodes. But in the meantime, check out my latest Period Party episode. And if you're looking for a deeper dive into your hormones, go ahead and take my period quiz at NicoleJardim.com/quiz.